Hi guys, how's everyone doing? Good. Thank you guys for all coming out today. I'm glad it's today and not yesterday when it was raining like cats and dogs. So I think we would have had a quarter of the people here if it was bad weather. But thanks for making it out. My name is Rakesh Patel. I'm one of the spine surgeons at the University of Michigan. I also serve a dual role. I am also the head of our marketing committee and our outreach committee. So our whole goal with this outreach committee is to be able to answer your guys' questions in a short, concise, half an hour, 45-minute talk with time for questions afterwards. I know that a lot of you probably have questions, but it's very difficult to make it into the doctor. And no matter who you see, we just don't have a half an hour to chat with you and to answer your questions. It's usually a 5-minute visit. And you go home and you're like, geez, I wanted to ask him a whole bunch of other things and I forgot. Well, today, hopefully you can learn some stuff about spinal stenosis and you can feel free to ask questions. You guys have some comment cards. It's very important that you fill out those comment cards because we try to give a lecture once a month on a different topic. So today's the spine, next time will be a hip or a joint, or it's some relevant orthopedic topic. And your input will make these talks better in the future. So please fill out those cards if you could. So first of all, by show of hands, who has back problems in this room? All right, that's good. All right, who doesn't have back problems? No, that's not true. My back's not so great either. Okay, who's had back surgery in this room? All right, good. And for those of you that have had your back surgery, how many still have pain? You can put your hand up. Okay. Last question. How many have heard that spine surgery is absolutely the worst thing in the world and no one ever does well from it? Yeah, Uncle Bob or Aunt Judy, someone had surgery and they never walked again and they were always worse. That's kind of like my friends that go to Vegas and they say that they always win. If they always won, Vegas would not exist. So, you know, it's all about who you talk to, and in terms of surgery, it's all about who you operate on and what you operate on people for. I think that myself and my partner, Dr. Greg Graziano, who's also going to try to stop by tonight at the University of Michigan, we both try to maximize people's non-operative care. We're firm believers that if you don't need to operate, don't operate. But if everything else fails, then surgery is indicated in some select people. Today we're going to talk about spinal stenosis. Spinal stenosis is a good topic because it's one of the most common spine afflictions that we see in our clinic. I know you guys have heard a lot of terms, and I'm going to throw some terms out. Bulging disc, everyone heard of a bulging disc? And has anyone been told they have arthritis in their back? Yeah, okay. Has anyone been told they have a slipped or a ruptured disc? Yeah, okay. So all these things kind of all mean the same thing. So arthritis in the spine leads to spinal stenosis. Anyone have arthritis in their hands or know people that have arthritis in their hands? You know how your knuckles get big and swollen? So that's the same thing that happens in your spine. And it's a whole aging process that includes your disc wearing out, your joints getting big, and all that leads to compression of your nerves. And that leads to spinal stenosis. And spinal stenosis is a general term for nerve compression. And we'll go into more detail about that. And by the way, this is really a laid-back kind of talk. If you guys have any questions, please ask me. At the end, you could ask specific questions relating to your case, but if you have any questions about the content of the talk, please stop me, feel free. So our goals in this talk is this is the same talk I give the medical students and the residents, so you guys are going to be just as smart as the doctors that you see. We're going to talk about the anatomy of the spine. We're going to talk about the clinical presentation. So what does someone with spinal stenosis come to you with? What symptoms? We're going to talk about what your treatment options are, and once again, these range from non-operative treatment options to surgery. So lumbar spine stenosis is extremely common. It affects roughly 10% of the people in the United States, and it's one of the most common reasons for spine surgery in the elderly population. And the number elderly means different things to me as I get older myself. But essentially, anyone who's in their late 50s, 60s, and upward has a good chance of having spinal stenosis. A lot of surgery is done for this. So over 125,000 laminectomies were done for this in 2003, and that number has been eclipsed over the last decade, so it's almost twice as much. I mean, that's a lot, 250,000 people getting surgery for this condition. And the amount of money that it costs the healthcare system, you, from time off of work, is tremendous. Billions of dollars, literally. So first we're going to talk about the anatomy of the spine. The spine consists of the cervical spine, the lumbar spine, and the thoracic spine and the lumbar spine. The cervical spine is the upper part of the neck. The thoracic spine is the vertebrae that are attached to your ribs. And and the lumbar spine is the lower spine. So today we're going to focus on the lumbar spine. Typically, the spine is made up of a bunch of blocks that are stacked up on top of each other, separated by a disc. And a simple way to imagine what a disc is, it's like a jelly donut. Literally has a thick outer layer and soft jelly inner layer. The whole goal of the disc is to help with absorbing compressive loads on your back, much like the shock absorber in your car. So if you have bad shocks in your car and you go over a bump, it's a very rigid ride. You have bad discs in your back that aren't doing their purpose, you're going to have back pain. Typically, in the lumbar spine, there are 5 lumbar vertebrae. And you count from the bottom. So this is L5, L4, L3, L2, L1. And the discs in the middle are named for the bones above and below them. So for example, this is called the L4-5 disc. That's the disc, that's the L4 bone, that's the L5 bone. I'm sure when you guys read your MRI reports, you read herniation at L4, L5. Now hopefully you know what that means. Okay? Let's see. So if you were to take a cross-section of your spine, so if we were to cut you in half, this is the view that we would have. I always tell all the residents and the medical students that you could consider your spine to be like a bunch of little tripods stacked up on top of each other. In the front, there's a disc, and in the back, there are 2 facet joints. So each vertebrae is connected to the one above and below it with a disc in the front and 2 facet joints in the back. Okay? And these facet joints, which are right over here, are just like your knuckle joints. They're the same shape and same size. Typically, a disc is very healthy, and once again, it acts as a shock absorber. And right behind the disc is a spinal cord, and then the facet joints are in the back, and then you have your spinous process, the bump that you can feel when you touch your back. There's something called the Degenerative Cascade. As we get older, our discs lose their shock-absorbing property. That jelly kind of disappears a little bit, and your disc becomes stiff. As your jelly disappears, your disc kind of deflates. So if you have less air in your car tire, you know how the side kind of pooches out if you look at someone's car that has less air in it? That's what happens to your disc. So the disc pooches out, and it bulges right into the spinal canal. So that's what a disc bulge is. It's a generalized pooch of your disc. Everyone has one. You shouldn't be so concerned about that term, but that's what it is. So once that disc kind of pooches out, if you can imagine that tripod, if the front leg of it is a disc, if you cut the front leg of a tripod off, it gets to be a little bit wobbly and unstable. Because it gets wobbly and unstable, your body tries to stabilize it. And the way it does that is by forming bone spurs. Bone spurs are big hunks of bone that surround a joint and try to stabilize it. So then you get bone spurs on these nice facet joints, and they start encroaching upon your spinal canal. The last thing that it does is it takes ligaments which connect one vertebrae to another, and it thickens them up to prevent that instability from happening. And these ligaments is this yellow thing right over here. That's called a ligamentum flavum, and it gets really thick. So now you can see pretty clearly from this picture to this picture how the combination of a disc bulge, facets getting bigger, and your ligament thickening takes your spinal cord, which is this purple circle, and makes it more like a triangle over here. Is that fairly clear to see? Okay. All right. And that's spinal stenosis. If you look at someone's spine from the side, this is someone's back, right? These are the spinous processes. This is L5, L4, L3, L2, and L1. Your spinal cord should freely flow in between them. But because of the combination of the disc bulge, the ligament hypertrophying, and the facets getting bigger, your nerves get pinched. They can be pinched in one spot, or they can be pinched in multiple spots. So when someone does have spinal stenosis, the first thing I like to do is, in terms of imaging, is to get an MRI. MRIs are great. I give a lot of credit to the doctors that practice before MRIs. MRIs are different from X-rays. Does anyone know how MRIs are different from X-rays? Okay, so there's not one that's better than another. They're complementary tests. X-rays show bone really, really well, which is very important for us to have. So some people get pretty upset when I say you need an X-ray. They're like, why? I have an MRI. They're 2 totally different things. It's like you need transmission oil and you also need gasoline to make your car run. You need both things. And an MRI is really good at showing soft tissues. Soft tissues meaning disc, nerves, things that aren't solid bone. So if you take a look at this MRI, that same picture that I showed you, that schematic of an axial cross-section of the spine, that's what this is. So in this picture, someone is laying down, their feet are coming out of the wall. This is their buttocks over here, their stomach's up over there. That's their left side and right side. Does that make sense? Orientation? Okay. And the spinal cord, which should be a nice big circle, is this little narrow triangle, just like we showed you on that picture diagram. And that's because of this big bulging disc, these big joints, and this black stuff, which is a ligament. You can barely see the spinal cord. It's really, really, really badly being pressed. So when someone has spinal stenosis, their spinal canal actually gets narrower when they stand upright. When the spinal canal gets narrower, it causes that back, buttock, and leg pain that people classically experience. When you flex forward and lean forward, the pressure gets lifted off the nerves, and people feel significantly better. So here's a good picture of that nerve being pinched right over there, and you flex forward, and you can see how that hole is wide open for the nerves now. So people often have pain in extension when they stand up, and they get relief when they bend forward in flexion. So what are the symptoms of spinal stenosis? So the first thing I tell the residents is don't look at the films when you see somebody. First go talk to the patient. That's by far the most important thing. And it's very classic what the symptoms are. People will say, Doc, you know, when I stand up for any length of time, it hurts like crazy. I can't wash my dishes. I can't cook. I can't do basic things. And I think it's really good to kind of not just think about when it hurts you, but look at what things functionally in your daily life you can no longer do. So people will always tell us when we go shopping, it's really difficult. I can't walk for an extended period of time. I have to walk hunched forward, and I have to lean on a shopping cart when I go in the grocery store. If I'm going to the park, I have to stop multiple times and sit at park benches, which I never had to stop at before. So these kinds of functional things are really important questions to ask. And once again, people feel better when they lean forward or when they sit down because, as the previous slide demonstrated, in that flex forward position, there's a lot less pressure on the nerve and it takes away the pain. Is that fairly clear? Okay. How many of you guys have noticed that in your own personal lives where you have those limitations? Yeah. Okay. Also, when you guys are walking in, you know, I see a lot of you people walking in that hunch forward position. And it's not, oh yeah, I'm getting older, that's why I'm walking that way. No, it's because your body is subconsciously doing that to help you alleviate your pain. So once again, the classic presentation is dull aching pain that starts in your back and goes to your buttocks. You have pins and needles kind of sensation. Some people can have weakness and also a lack of balance. People often start using canes and walkers just to get that leaning forward effect. You can't walk as much. If you don't work out, you lose the ability to walk. The less you walk, it's a really nasty spiral. The less you walk, the less you end up walking in the future. After a year, you'll see your walking is really severely diminished. And it could also present like sciatica. Typically, sciatica is different than stenosis. When people have sciatica, they have that one pinched nerve that just zings down their leg. It doesn't matter what position they're in, typically worse when they're sitting. But once again, in spinal stenosis, it's worse when they're standing and when they're walking. So what happens when you have spinal stenosis? Well, if you can't walk, you gain weight, and gaining weight is always a bad thing. I'm 36 now, and I go to the gym quite a bit, and I know that it was much easier to get in shape when I was 26 as opposed to when I'm 36, and that effect gets magnified every decade. So when I'm 66, like my dad is right now, I know it's much harder for him to, you know, lose weight and keep in shape than it is for me. Overall, you deteriorate. If you can't walk, you start gaining weight, you start getting lung problems, your other joints start breaking down. And honestly, it's depressing. I had a patient tell me once that the golden years aren't really the golden years, they're the rusty years. And I thought that was an interesting comment because, you know, you work your whole life and you kind of want to live, travel, and do fun things. And you get to that great stage in your life where you're supposed to enjoy yourself and you just can't because you can't walk. And a lot of people get depressed from this. It's a very, very common problem. And if you have other comorbidities like lung problems or heart problems, they only get exaggerated and worsened by not being able to ambulate. It's very important to remember a couple of things. One really important point I'm going to make over here, and this is one of the top 3 take-home points of the day. So if you can just remember this, this would be really useful. Not everyone with spinal stenosis on an MRI has symptoms from it. Okay, I'm going to say that one more time. Not everyone with spinal stenosis on an MRI has symptoms from it. The reason why that's important is because if I got an MRI on everybody's spine who is age 50 or above, it's going to show something on that MRI report. It's going to show a bulging disc. It's going to show some arthritis. There's going to be some negative comment on that report. Unfortunately, unless you're a spine surgeon, people don't know how to interpret that report. Much like you don't want me reading your EKG because I know nothing about hearts anymore. Your primary care doctor knows nothing about spine MRIs. They'll only read that radiologist report. That report means nothing without talking to the patient and seeing if their symptoms are actually coming from that. My MRI, I have a herniated disc on my MRI. It means absolutely nothing. I have no pain from it. It's not bothering me. It's just like having gray hair or no hair in my case. It doesn't really affect me. I could live my life just totally fine. So it's a really important point to remember. Most people will come to me and they'll be in a panic and they'll say, "Doc, my back is horrible. I have 6 slipped discs and I have this and that." And I talk to them and their symptoms are not coming from any of that stuff. Another thing that's important is that when someone comes into your office with difficulty walking, I know for me, being a spine surgeon, the first thing that goes off in my mind is, hey, does this person have a spine problem? But you also have to think outside the box, and it could be something totally different. It could be their hips. Hip arthritis is a very common cause of leg pain. And if you think about it, it presents very similarly. You have pain when you walk, you have no pain when you sit, it limits your function, and you would be surprised at how many times I've seen patients that have had back surgery and they come to me and say, "Doc, I'm no better, what's going on?" And in a 5-second exam, I could tell that they should have never had their back surgery. They were just one of those people who had an abnormal MRI, but their symptoms weren't coming from the MRI, it was coming from their hips. They get a hip replacement and they feel wonderful. And the same reverse situation applies too. I see people that have hip replacements and they don't get better, and the problem's actually coming from their back. It could also be greater trochanteric bursitis, big fancy word for a little bit of inflammation on the sides of your legs. So my partner in my practice said one day, "Hey, Rock, you got to see me right away. I think I have a bad spine problem and I may need surgery." Now, granted, this guy's a hip surgeon, and he's an older hip surgeon, 20 years into practice. So I said, "Not a problem, I'll see you right away." I saw him the next morning, and he was convinced that he needed surgery for his back. I pressed on his hips right on the side, right over here, and he started hurting. And I asked him a couple of relevant questions. I said, "Does it hurt you at night when you sleep?" And he said, "Yeah, it hurts like crazy. I roll from side to side all night and it hurts like mad." And after just talking to him for 3 seconds, I realized it's not a spine issue. It's just inflammation of the hip bones over here. So I'm sure a lot of you guys have that symptom. Just by show of hands, pain on the sides when you sleep? Yeah, so that's not to say you don't have a spine problem, but you also have something else in addition to the spine problem. Meaning if we did spine surgery on you, that wouldn't go away. That would still remain because that's a totally different problem. And lastly, vascular claudication is very, very commonly confused with spinal stenosis. So vascular claudication is when you don't have adequate blood flow to the muscles in your legs. You get older, your arteries aren't the same, your veins aren't the same, and your heart's not pumping the same. And very similarly, if you walk, your legs get tired and fatigued. There are a few subtle things that we ask patients to help us differentiate between whether your pain is because of your nerves or because of your blood vessels. One of the things is that if it's because of the blood vessels, regardless of what position you walk in, the pain doesn't get better. The reason why vascular claudication hurts is your muscles need blood to function. So I don't know if you guys are runners or bikers still or were in the past, but after you run for a while, you get that burn in your legs. That burn is because you don't have adequate blood supply and oxygen to that muscle anymore. So in spinal stenosis, if you lean forward, you take the pressure off the nerves, you feel better, you can keep walking. In vascular claudication, no matter what position you're in, as long as you're using those muscles, it ends up hurting. So that's one important question that we ask. And we ask a whole series of them to differentiate, but the whole purpose of this slide is to realize that MRIs showing spinal stenosis don't necessarily mean that patients have complaints from their back. It could be other sources. So what do you do when patients have spinal stenosis, or you think they have spinal stenosis? Do you operate on every single patient right away? And once again, absolutely not. I think that non-operative treatment is by far the best thing. Staying healthy is really good. Physical therapy for core strengthening, trunk stabilization, and maintaining as much walking you can do is fantastic. Anti-inflammatory medications over the counter like Advil or Aleve are great. But that doesn't often help. I mean, I'm sure a lot of you guys have tried that, and it only gives you minimal relief. One thing that I am completely opposed to is narcotics for pain. That is a pet peeve of mine. I'll see patients that get put on Vicodin, Percocet, OxyContin, oxycodone, methadone. I mean, really big narcotics. And I think narcotics are fine for a short period of time if you have a problem which has a firm endpoint to it. But if you don't, you're just creating another problem. It's not a question of your integrity or your morals. It's simple biochemistry. If me, you, or the Pope took Vicodin for over 2 weeks, our body develops some kind of baseline dependence to it. It makes it that much harder to get off of it, and it's not really solving any problem. So I think that anti-inflammatories are great, but I'm not a big fan of narcotics for the long term. Exercise and weight reduction is great. That helps overall conditioning. But the first invasive therapy that we ask people to get is an epidural injection. Have you guys ever had epidural injections? Show of hands. Yeah. Okay. Another show of hands. For how many of you was that experience miserable? Good. Okay, one person, maybe two. So out of all the people that raised their hands, most of you guys had a positive experience. The second I mention epidural, people freak out. They remember someone giving birth and an epidural being popped in and causing a lot of pain, leading to a lot of problems afterwards. That's not the way it works. Epidural injections, the word epidural refers to the place where the medicine is being injected. Epidural means next to the dura, and the dura is a thin layer surrounding the spinal cord. It's the same thing as a cortisone shot to the spine. Cortisone is what you're injecting in the epidural space. Does that make sense? Okay. So my wife had an epidural and she had a C-section, and it was kind of an emergency. And in that emergent situation, they just kind of feel, poke, and go at it. When you're having an epidural, most of the times people are sedated, so it doesn't hurt them very much. They're using big X-ray machines to make sure the needle is being localized and sent in the correct location. And they can't do any of that stuff in an emergent situation when someone's pregnant. So it's really not that horrible of an experience. I like epidurals for a couple of reasons. That steroid really takes the inflammation off the nerves and it makes you feel better. The question is, how long will it make you feel better for? And I don't know what the answer is. For some people, they get an hour of relief, some people get a day of relief, and some people get a year of relief. You can get 3 to 4 epidurals in a year. So as long as you're getting 3 to 4 months of relief, if it was my father, I would tell him, keep getting epidurals. And this is coming from a guy who makes his living by operating on people. If you can get away with 3 to 4 injections a year, that's better than having any spine surgery you could possibly imagine. The problem comes into play when your epidural gives you 2 weeks of relief or a month and a half relief. Then I don't think it's worthwhile to get multiple epidural injections because you'll have pain relief for only a small part of the year and you'll be miserable for the rest of the year. Another reason why I like epidural injections is because it is a good indicator for me for how well you'll do after surgery. So if you remember, I said that not everyone with spinal stenosis has pain from spinal stenosis. So one way for me to confirm that your pain is actually from your spinal stenosis is to send you for the shot. If it is from the stenosis, you will typically, not always, but typically get relief, even if it's for an hour. I don't care. You'll get some relief for a short period of time if your symptoms are coming from the injection. And we can always tell people that your postoperative pain relief will be roughly the same as the maximal pain relief that you got from that first epidural injection. If you've asked people that have had lumbar laminectomies and things that have gone well, they'll tell you that's about fairly accurate. And after a laminectomy, typically your pain relief is permanent as opposed to the epidural injection where it works for only a short period of time. So the term laminectomy gets thrown around a lot. The lamina is the, God, I should have shown you guys this before. I'm going to go back in the slides really fast. No one get nauseous. Okay, right over here. So if you're laying down, this is your buttocks, this is your stomach, your feet are coming out of the screen, this is your left side, and this is your right side. Is everyone oriented fairly well? Okay. So this is the disc, like we said before. These are your facet joints. And see this bone that I'm outlining right now, the one that looks like the letter Y? That's called your lamina. If you feel your back, that's the point that you're feeling. And if you go further down, which you can't feel because your muscle is right over here on either side of this is your lamina. So in a laminectomy, what we do is we remove the lamina. Ectomy is just a fancy medical way of saying removal. So laminectomy, remove the lamina. So we actually will take a surgical instrument and make a cut over here, and remove this entire bone and the ligament around it and take the pressure off the nerves. By doing that, that alleviates your symptoms. You don't need that extra bone there. It's not necessary. It's not protective. It just happens to be there. So that's what we do in a laminectomy. Most of the times when we do spinal stenosis, a laminectomy is good enough to take away your pain. It's the most common surgery that we do for spinal stenosis. It's typically done under general anesthesia. It takes anywhere from an hour to 2 hours for each level. If you're having 3 levels done, meaning if you have stenosis at multiple spots in your spine, like L2, 3, 3, 4, and 4, 5, we would do a 3-level laminectomy. That would take a little bit longer. Each added level would take another half an hour or so. And most people do really well. Here's a picture over here on the side of what your spine looks like after laminectomy. You can see that a trough of bone has been removed, your spinal cord is exposed, and all the pressure is off of it. A lot of people really get nervous when the word fusion gets thrown out there. When do you have to fuse in a patient with spinal stenosis? You don't really have to fuse too often when someone has spinal stenosis. The main reason to fuse someone with stenosis is if they have any instability preoperatively. So if you look at this film over here, once again, this is L5, 4, 3, 2. You can tell that there's no disc between L4 and L5, like there should be. At L3, L4, you can see there's a nice disc, but not at 4, 5. Is that fairly clear to everybody? Okay. The blocks of the spine line up pretty well. If you look over here, this bone is shifted forward in front of that bone. Is that fairly clear to see also? Okay. So that slip is the reason why this person has spinal stenosis. That slip is because of arthritis. The disc is worn out, right? The first stage of the whole cascade that we described. It's unstable, and you've gotten that slip. If we do a laminectomy in this person and remove the bone in the back, we're going to destabilize it even further. And this L4 vertebrae is going to shift forward even further. So in this situation, we have to add a fusion onto it. And when we fuse, we typically do it with screws and rods. We'd put a screw in at L4, screw in at L5, and a small rod linking it. It's funny because people cringe when you say the word fusion. But the fusion aspect is honestly the easiest part of the case. In this situation, there's going to be no decrease in their range of motion because they don't have normal motion to start with. You need a normal disc to have normal motion. In fact, with a decreased amount of pain, their motion actually typically improves. And people, I think, have a bad idea of what a fusion is because you talk to people that have had fusions for back pain and they haven't gotten better. Now, those are 2 totally different circumstances. So a fusion for back pain is a procedure where you're trying to fuse someone's vertebrae to get rid of their back pain. A fusion in someone that's getting a laminectomy is totally different. And a fusion for someone getting a laminectomy is to prevent their spine from destabilizing and slipping forward more in the future. The stenosis patient's not going to get better with the fusion. That's just a preventative surgical thing to do so they don't get worse in the future. But the laminectomy, taking the pressure off the nerves, is what's going to get them better. Does that make sense, everybody? All right. So, and honestly, the harder part is the laminectomy. The fusion part is not that big of a deal. So don't flip out if you hear, yes, you need a laminectomy and a fusion. Now you know why we typically do fusions in people. Sometimes when we're in surgery, we have to remove a good chunk of bone, more than we wanted to take the pressure off the nerves. If that happens, we can create instability. If we feel that we've created an unstable spine, then we'll decide to fuse also. But once again, the fusion is not the difficult part of the surgery. And this is a perfect example of that. This first MRI over here is someone with back pain. Their disc is dry, but they have no spinal stenosis. So this is a fusion for back pain. Their success rates are way lower, 60% maybe. So 4 out of 10 people that have fusions for back pain don't get better. So that's a totally different situation than this situation right over here, which is someone whose nerves are really badly pressed. We're going to take away bone, we're going to destabilize them, and that's a totally different situation. So this is what a film looks like on someone that's had a decompression fusion. These are the screws that we put in with a small rod. We also do some minimally invasive surgery, and people get really excited about minimally invasive surgery. I'll tell you right now that there's no proof in the literature that minimally invasive surgery leads to better outcomes than standard surgery. It's the sexy, in vogue thing to do. Often people will use it as a marketing tool. I'm sure who's heard of the Laser Spine Institute? Everybody, right? I mean, it's unbelievable. You fly an airline, you open that thing up, and people say, "Oh yeah, I had laser spine surgery, and I went home with just a Band-Aid on my back, and I played, baseball the same day." I mean, that's nonsense. Let me just clarify a myth. There is no such thing as laser spine surgery. It does not exist. No major spine society will ever endorse it. No papers of laser spine surgery have ever been published in any major spine society, nationally or internationally, so there's no such thing. I could just debunk that myth right now. The reason why I think minimally invasive surgery is good is not because it's more cosmetic. I don't think anyone in this room really cares whether their incision is yay big or yay big. I mean, you know, it's just not that important anymore. But if you can get away with disrupting the muscle underneath the skin, that's where the benefit of minimally invasive surgery comes into play. And not everyone is a candidate for it. And quite frankly, most people in this room would not be a candidate for it. Most people that are candidates for minimally invasive surgery are younger people with disease only at one level or on one side of their spine. So most people who have really bad stenosis are not great candidates for minimally invasive surgery, but some are. So it's always an option that we keep in the back of our minds. So what do you do if someone has failed non-operative treatment? They don't want surgery, the traditional laminectomy and fusion, they're scared of it, or understandably so, or you know, their doctor says, Mr. Jones is too sick, he's had bypass surgery, and I don't think he's going to withstand the stress of a major surgical intervention. There's another procedure called an X-stop, and the word, the procedure X-stop stands for extension stop. So you guys remember one of those first slides I showed you, when you extend, you squeeze the nerves. If you flex, to take the pressure off the nerves. So an X-stop is this little metal spacer that we put in through a small incision in between these bumps in your back. And basically it prevents these two vertebrae from extending because it's acting as a bumper in between them. This is a great procedure because it takes about 10-15 minutes to do. People can go home the same day or stay overnight. We're not exposing the nerves, so there's no chance at all of any nerve injury. But the downside of this procedure is that the success rates are less. Since we're not directly visualizing the nerves and taking the pressure off the nerves, our success rates are somewhere around 65% with this, as opposed to a traditional laminectomy where your success rates are 85%. Which one should you get? Well, if you're a candidate for an X-stop procedure, the decision is purely personal. Some people feel that if I'm going to have one surgery, if I'm going to have surgery on my spine, I want one surgery with the best chance of getting better, and I don't even want to think about going back. And those people should not get an X-stop. They should get a traditional laminectomy. Then you have the other group of people that say, well, I'll try the X-stop procedure. It's a safe 10-15 minute procedure. I have a 65% chance of getting better. If it works, great. No harm done. If it doesn't, I can always have the traditional laminectomy in the future. So it all depends on what your mindset is and who you are as a person. And here's a picture of the X-stop being placed right in between the bumps of the spine. A close-up view for it. And the indication for an X-stop procedure is someone with spinal stenosis that has relief when they sit, and relief when they bend forward and use a shopping cart. If your spinal stenosis is super, super severe, sometimes it hurts no matter what position you're in. It doesn't matter if you're sitting, it doesn't matter if you're on your head, it doesn't make a difference. If your stenosis is bad, no position is going to relieve it. Now those patients are obviously not a candidate for the X-stop procedure because what we're trying to do is mimic the position of your spine when you're sitting, when you're actually standing. So that's a brief rundown on the anatomy of the spine, on spinal stenosis in general, what your treatment options are. And I guess the floor is open to any questions. Yeah?
You have been talking about what you can do. What can we do? I, of course, would like you to support me doing Zumba and boxing, and which I do. And I think that is really why I'm standing here and not sitting down. Because you strengthen your core and proper nutrition and all of that. There must be a lot that we can do and not rely on you as a...
Well, I think it's well, first of all, if you never came to see me, I'd be a happy person. I'd rather meet you in a bar to have a drink than to operate on you. That's number one. Number two is you are fortunate to have good genes. No matter what you do, you can't prevent arthritis from happening. Well, I should clarify that. The number one reason why people get arthritis is genetics. So if your mother or father had arthritis anywhere in their body, you're prone to get it. Exactly. You can thank, those of you that came with your parents, thank them, give them a big hug and a kiss. The interesting thing about arthritis is it's not always clinically relevant. So you can have horrible arthritis in your back and you may feel just fine. So don't be really worried if your mom has arthritis because even though you may have it on x-rays and MRIs, it may not be symptomatic for you. Strengthening your core and staying active is really important. It's great to maintain your range of motion. It's great to maintain the health and integrity of your spine. So I do recommend that to everybody. Be as active as you can be. There are other things that you can do. Number one is watch your weight. The heavier you get, the more of a load it is on your spine, and the more likely you are to have degenerative disc disease. Something else that you can do is don't smoke. How many people in this room smoke? I'm not going to judge you. I'm just curious. Wow, it's a good room. I smoke cigars every once in a while, if that counts. But if you smoke, smoking is really bad for the health of your disc. It takes away the blood flow to your disc, and it gives you earlier degenerative changes. So weight loss, staying in shape, not smoking are the main things you can do. Otherwise, if you're going to get arthritis, you're going to get it, unfortunately. Yeah.
Does stopping smoking help after a while, or is it the damage is done?
No, stopping smoking definitely helps. In fact, if someone's going to have surgery by us, especially if we're going to do a fusion, we won't even offer a fusion to someone unless they've stopped smoking for at least 2 to 3 months. And people lie. So we end up doing urine tests to make sure that they don't have any nicotine in them. Only for their own safety, because people do better if they don't smoke. Yeah?
When you're talking about arthritis, are you referring to rheumatoid arthritis or osteoarthritis? Because they're two different.
Great question, yeah. So 2 main types of arthritis are rheumatoid arthritis and osteoarthritis. Rheumatoid arthritis is an inflammatory arthritis, and osteoarthritis is the typical wear and tear arthritis that we see. When we're talking about the spine, it's primarily osteoarthritis. Rheumatoid arthritis of the spine used to be a huge problem, and it no longer is because of the medications that we have. So the spine typically does not get affected with rheumatoid arthritis anymore. So, yes, sir?
If you once had surgery for spinal stenosis, does it keep progressing?
Yeah, so arthritis will always progress radiographically. So if you have arthritis in your knee, for example, if you got an x-ray 5-10 years later, that arthritis is going to get worse. Now, like I said earlier, clinically, you may feel better. And if you look, if you do a natural history study, that means if you take 100 people with, or whatever number of people with a certain condition, and you don't treat them, and you see what happens to them in the future, that's called a natural history study. One of the biggest spinal stenosis natural history studies has shown that a quarter of the people, 20% of the people actually got better. 40% of the people got worse, and 40% of the people stayed the same. It's really hard to do a good natural history study because people want intervention. If you came to my office and I said, hey, I'm just going to watch you, I'm not going to give you any medications or treat you, you guys would shoot me. So that's really difficult to do, but natural history typically dictates that things are going to get worse. So if you've had surgery at one level, there's a fairly good chance that you're going to have radiographic stenosis, at least at another level, and that may lead to symptoms. Now, if you have a fusion, then you're even more likely to have problems at the next level. Because what you're doing is you're making one segment really, really stiff. There's no motion there anymore. So all the stresses are going to be at the adjacent level. So that's going to wear down even sooner. And it's kind of a game of dominoes. That's why if you don't have to fuse, you don't fuse. Yeah?
I've had surgery for the stenosis, but he also says I have degenerative disc disease. What is that? So
just like I was explaining in that whole cascade of stenosis, the first step that happens is that disc loses its jelly, flattens out, and that's the first step of spinal stenosis. So degenerative disc disease is the first step of spinal stenosis. It's the beginning of arthritis in your back. All these terms are all the same.
So if you're still having problems, it's because of the arthritis now that's in my back?
No, if spinal stenosis happens because of arthritis in this demographic. So if you're still having problems, you may have spinal stenosis at a different level, or maybe something wasn't addressed. But it's not because now your discs are degenerating. That's part of spinal stenosis, so it was likely like that before. Yeah? I'm sorry. It's funny, they set up these mics so people can walk up to the front and talk, but people with spinal stenosis typically can't walk, so. Yes, sir.
Unfortunately, the lecture announcement didn't say that you were only going to talk about lumbar stenosis and I have cervical stenosis.
Sure.
How much of what you said applies to cervical stenosis as well?
Cervical, like we said before, is neck. Stenosis, same concept. It's pressure on your nerves. Cervical stenosis is a completely different animal, and it's a lot more concerning and a lot more severe than lumbar stenosis. If you never did a single thing about your lumbar stenosis, you may be able to walk less because of pain, but you'd never be paralyzed from it. And that's because the structure of your spinal cord changes at around L1. Above L1, so in your cervical spine and your thoracic spine, your spinal cord has a different structure where it's really thick, like a big thick cord. Below that, your spinal cord looks like a bunch of wires floating in a water balloon. Because those wires are less sensitive to pressure, you can't get paralyzed from lumbar spinal stenosis. From cervical spinal stenosis, you can get paralyzed. Also, if you have cervical spinal stenosis and if you have the associated symptoms of cervical spinal stenosis, which are clumsiness in using your hands, difficulty with coordination. Those are the main symptoms that people have. Difficulty buttoning your shirt. When you stand up, you feel like you've had one too many martinis. You feel a little bit woozy right away. These are classic symptoms of cervical stenosis. And for that, we don't recommend epidurals or anything. We recommend surgery. The main reason why we recommend surgery right away for cervical stenosis is people don't often get better, but we want to prevent them from progressing and getting worse. Cervical stenosis will ultimately lead to people being in a wheelchair. So that's why we try to intervene right away. With that being said, just like your lumbar stenosis, many people have cervical stenosis, but they don't have those classic symptoms that I just described. So if you don't have those classic symptoms that I just described, there are a few things we look for in physical exam. If you don't have them, then it's just a radiographic finding on an MRI, and then we don't rush to operate, or we don't even consider operating. Yeah, we'll just keep working back in the room. We'll come back around. Yeah.
So you said weight loss and exercise. What kind of, since those people can't walk, what kind of exercise do you recommend?
So bike riding is fantastic. Almost everybody can sit on a bike and ride because it doesn't involve... Swimming is great, but unfortunately, when you swim, you're in an extended position, so that typically hurts your back. When you're in a flex forward position, it doesn't hurt at all. Actually, I had someone that couldn't even do his own grocery shopping, but he would ride centuries, which are 100-mile bike races, without a problem. And I don't know if you guys have ever taken a spin class. I highly recommend them, and they are exhausting. So it's a really good form of exercise. Yes?
Spinal cord stimulators, I mean, I've heard of them as being helpful, are they?
So spinal cord stimulators, the question was spinal cord stimulators, are they helpful or not? So spinal cord stimulators to me are kind of a last line effort. So when we take the pressure off of someone's nerves, we typically expect them to get better. However, if your nerves are chronically injured, sometimes you just don't improve. So I always tell patients that the success rates of these surgeries are around 85%. Hopefully more like 90%, but there's always a subset of people that just won't get better. So if you have a patient that's not better, and if you can prove after surgery, you get another imaging study, and if you can prove that there's nothing pushing on their nerves, and it's chronic nerve injury, then that's when a spinal cord stimulator would be beneficial. And for those of you that don't know, a spinal cord stimulator is essentially a couple of electrical leads that go to your spinal cord, and they're attached to it like a beeper. And during the trial phase, the beeper will be set to give your spinal cord a certain amount of stimulation. If your symptoms go away with that, then they will get rid of the beeper and they'll implant it through a small incision underneath your skin. If it doesn't help you, then all they do is pull the wires out and you're done. So yeah, last ditch kind of effort. Let's start from here. We'll work our way back again. Yes?
Back to cervical stenosis. Can that cause urinary retention, other urinary problems?
It can, but so can lumbar stenosis. Lumbar stenosis can cause urinary problems, so could cervical stenosis, but the amount of stenosis would have to be severe in order for it to happen. And it's really tough because you get people who are in their 70s and 60s and 80s with urinary problems, and that can often be completely independent and usually is independent of their spine. It's usually a GU-related issue and not usually a spine issue, but it certainly can be. Yeah?
What's the role of gabapentin or Neurontin in the treatment?
Okay. So the question is, what's the role of Neurontin or gabapentin for the treatment of this? Has anyone else over here been on gabapentin or Neurontin? Okay. Yes, quite a few. Gabapentin or Neurontin are seizure medications. They affect the way an electrical impulse gets transmitted down a nerve. If I have someone that has nerve-related pain because of stenosis or a herniated disc, I would much rather you be on gabapentin or Neurontin than Vicodin or Percocet, which is just going to make you, kind of woozy and kind of sedate you a little bit. So it's more effective for nerve-related pain. I think it's a really good option. The third medication is gabapentin and Neurontin are the same thing. One's generic and one's the trademark name. But Lyrica is another medication which is also fairly effective for that. Any more questions on this side, sir?
Yeah, you mentioned the ligaments thicken. I didn't recall. What causes the ligaments to thicken?
So once again, the basic concept is the tripod, right? So your spine's a bunch of tripods stacked up on top of each other. Disc in the front, two facet joints in the back. First thing that happens is you get degenerative disc disease, and that first leg of the tripod gets cut. your tripod gets a little bit wobbly, and your body's impulse and reaction is to stabilize your spine. The way it does that is by making big bone spurs to encapsulate those facet joints in the back, those other two legs of the tripod, and it thickens the ligaments in the back as an attempt to stabilize your spine also. So kind of, the ligaments are like reins on your spine, and it'll thicken them to prevent any more motion. So it's that instability that happens with the degenerative cascade that leads to the ligaments getting thick. Okay, we'll just go around. Yeah, sorry, actually.
What's the timeline of the progression to degenerative and different phases?
It varies. Some people are predisposed to having it at a very early age, and some people get it later. Some people have horrible, once again, radiographic findings and no symptoms from it. So the timeline doesn't really matter because the timeline only indicates what your spine's going to look like, not how you're going to feel. Stenosis is a threshold disease. So when I see someone that says, "Doc, for the past 2 months my spine's been killing me," I look at their MRI and it looks like there was a war in there, and I know it's looked like that for 20 years. Why is it only the past couple of years they've been having pain? It's because for some reason you've passed that threshold where it's now significant for your body. And it's really important because the threshold is different for everybody. For some people, if they have 25% occlusion of their spinal canal, that'll cause them severe symptoms. For some people, they could have 90% occlusion of their spinal canal and have no symptoms. So it's a threshold disease, and the threshold is different. That's why the radiographic finding doesn't matter as much to me as your clinical story. Yes, sir?
I'm having some burning sensation right from the hips downwards to the toes, through the legs. And I'm taking gabapentin. The diagnosis is that progressive deterioration of the nerves.
Yeah, so the nerves will, so you could think of your spine as a tree trunk, and you could think of the nerves as branches. They'll exit off the tree trunks and they could follow their own path. So your branches could be injured right when they're coming off the tree trunk or anywhere along its path. So your nerves similarly can be injured or compressed in your spine or anywhere along the course of your leg. Your nerves can also be injured for other metabolic things. So people that have diabetes can have neuropathy. Have you guys heard of that term? Right, so neuropathy is a problem that's in the nerves after it leaves the spine, and there's no compressive source. There's nothing pushing on it. It's more of a metabolic thing. It's because of the nutrition that you have, because of the other medical problems you have like diabetes, and that presentation is slightly different. And honestly, each case needs to be examined on an individual basis. You can have stenosis and neuropathy. They're not mutually exclusive. You can have a flat tire and you can have, low engine oil. You can have multiple problems going on at the same time. And your symptoms sound like they have some component of spinal issues, just judging by what you're saying. Neuropathy typically presents in what we call stocking glove distribution. So people will have burning and an awkward sensation in their stockings, in the gloves and their stockings, which is, they're basically knees down all the way around your foot.
Can it be cured or
Neuropathy is medications. And, once again, if something's pushing on your nerves like stenosis, it can certainly be cured. Yeah?
Can you talk about nerve ablation?
Yeah, so the question is nerve ablation. The nerves that come off your spinal cord and go down to form the sciatic nerve and supply the muscles in your legs, you don't want them ablated. Because if they're ablated, then you're not using your legs anymore. The nerves that people typically ablate are tiny branches that kind of look like a hair that exit off and supply those facet joints in the back, the back two legs of the tripod. Like I said, once a disc degenerates, those two facet joints in the back get arthritic, and arthritis hurts. Those joints look just like your knuckle joints. When your knuckles get arthritic and you bend your fingers and you make a fist, it hurts. So what they'll do is they'll ablate that small hair-like nerve that provides sensation to those facet joints, to those small joints in the back.
Is that helpful?
It's helpful if that's the source of your pain. Once again, I go back to cars because we're all like cars. We eventually break down. So, is changing your engine helpful? Well, if the engine's a problem, the reason why it's not starting, then it's very helpful. If it's not, then you just paid a guy a lot of money for nothing. Yeah?
Do you have some other suggestions of non-narcotic drugs? You talked about gabapentin, Lyrica.
And anti-inflammatories like Advil, Aleve. Those are the mainstays. Tylenol's fine if it works for you. There's nothing addictive about it, So yeah.
Does scoliosis have any relationship? Are you more apt to get stenosis if you have severe scoliosis?
So the question is scoliosis going to cause stenosis? That's a really loaded question, because you can talk for days just about scoliosis and different types of scoliosis. But in general, when someone has scoliosis, their spine is no longer straight and it's curved. If it's very severe, your discs wear out asymmetrically. So if you're really, if your feet are really flat-footed, when you run, if you look at someone's sneakers, the inside part's going to be more worn than the outside part. Similarly, if your spine isn't stacked on top of each other straight and is really crooked, that's going to lead to more pressure on one edge of the disc and it's going to wear out. And that can certainly be a predisposing factor for degenerative disc disease and subsequently stenosis. Yes?
What would be the symptoms for thoracic?
Very similar to cervical stenosis.
Is it as serious?
Yes. Yes, sir.
What is the relationship between stenosis and the formation of Bursa, painful Bursa?
0. So the question was, what's the relationship between Bursa and stenosis? Does everyone know what a Bursa is? You hear that term all the time. Oh, I got bursitis, and that's a very common thing that people say. A Bursa is a fluid-filled sac that acts as a lubrication between a bony prominence, like your elbow, and muscle that glides over it. So you have a bursa in your elbow, you have a bursa in your shoulder that helps the muscle glide over the bone. In your hip, if everyone just presses over here, you have a big piece of bone there and you have big muscles that go over it. So the bursa acts as a jelly-filled sac that helps lubricate that. So bursitis is just inflammation of that bursa. It can be exceedingly painful, but there's no bursa in the spine itself. So that's why it's not related to spinal stenosis. Yeah, sir?
If you get a laminectomy and the pain hasn't gotten any better, you're saying that surgery is really not going to help you?
No. I think whenever someone comes to me, we see a lot of patients that have had surgery elsewhere and haven't gotten better. That's probably the majority of what we see. And I think there are a few key questions you have to ask that patient. You have to ask, did you ever get better? Were you better for a short period of time, for a week, a month, a year? And if they say, yeah, I was better, I call that the honeymoon period, where things were all real dandy before reality set in. And if you have a honeymoon period, that means that the proper thing was addressed, you did well from it for a short period of time, and now something else is causing your problem. In the world of spine, it could be spinal stenosis at the next level above or the next level below. Now, if the same patient came to me and said, yeah, I had surgery and I was never better, not even for a month, then it could be one of a few things. One is the surgery wasn't done appropriately. Another thing is that the surgery wasn't indicated, meaning even though there was stenosis on the MRI, your symptoms could be coming from something else like hip arthritis or something. So it really depends on the exact situation. But because you didn't get better with the laminectomy doesn't mean that you're not going to get better with any spine surgery or with any other type of surgery, whether it be your spine or your hips or your knees or whatever the case may be. Yeah, let's start in the front. We'll go back again. Yeah.
A laminectomy requires a typical stay in the hospital. About how long, and about how long does a laminectomy require for recovery?
Okay, so the question is, laminectomies, how long do you have to be in the hospital? And it clearly differs from person to person. So you, for example, are different than the gentleman sitting next to you, clearly. The best indicator of postoperative function is preoperative function. If you are someone that has stenosis, yet you can walk a half a mile and you have no other medical problems, no heart problems, no lung problems, and you're one of the younger people on the spectrum, if you're 50 years old, then your recovery time is going to be a lot shorter. You'll be in the hospital for maybe a couple of days and you'll go home and you'll feel great after a few weeks. Laminectomy doesn't typically have the same restrictions that a fusion does. And most people can go back to doing most things in 6 weeks or so. If you are on the other end of the spectrum and you have multiple problems, heart issues, lung issues, you really weren't walking much before surgery, your capacity to walk was maybe from here to the door, then the recovery process is obviously going to be a lot longer. There are two phases to the recovery process in that demographic. The first is the acute phase, making sure that you live, making sure you get past the lung issues and the heart issues and actually make it out of the hospital, which most people do. And then the second stage is the recovery aspect of it. If you weren't walking much before, your muscles have become really deconditioned, and it takes a long time to get that back. It's funny, I'll do a case and I'll be so happy because the nerves are horribly pinched. We take the pressure off the nerves, and I expect that person to bounce right back. And I have to really think and say, hey, listen, this person's been in a wheelchair for a year. They're not going to be running a marathon, next week. It takes a while to build it back. So it's all based on your preoperative function. Actually, this lady, then I'll come to you.
Can spinal stenosis cause neck pain?
Cervical spinal stenosis can. Lumbar spinal stenosis definitely can't. Yes, sir.
Can I ask you a connected question to the previous question I posed to you? When I'm sitting as if I'm on fire, but I walk, that does me good. Why so?
So it's probably not spinal stenosis in that situation. It's probably not spinal stenosis in that situation because you have the opposite effect, where you have pain when you sit, when most people with spinal stenosis get pain relief when they sit. Yes, ma'am.
Can you tell me if inversion clinically does or does not help spinal stenosis?
So the question is, does inversion, where you get put on a table, like, can tip you so your feet are above your head, does that matter in spinal stenosis? There is no proof that that helps in spinal stenosis. I don't believe that it helps in spinal stenosis because I'm a man that needs proof for everything in life. If you want to try it, go right ahead. I don't mind people trying things that aren't going to harm them. So it's certainly not going to harm you. So if you feel that it's something that you want to try, I have no problems having you try it. It's the same thing when my parents called me up and asked me about acupuncture. I'm like, hey, Rock, should we try acupuncture? I have this problem or that problem. I told them the same thing. I said, I don't believe in it, but if you want to try it, go right ahead. It works for some people, and I don't pretend to understand why certain things work and don't, but there's no harm in it. So I think it's a valid option if it's something that you believe in. Yes?
I've heard of something, I don't remember the term, kyphos something or other.
Kyphoplasty.
Thank you. Which is to re-expand a compressed disc.
No.
No?
Yeah, so
there I'm wrong. How does this play?
Okay, so kyphoplasty is a procedure where we inject cement inside the bone. And then the indication is totally different. So kyphoplasty is a great procedure if someone has a compression fracture of their spine, meaning a bone in their back is broken. If the bone in the back is broken, it causes pain, much like if you broke your wrist, it would cause you pain. So what we would do is we would put a balloon in, inflate the bone, so the bone reestablishes its height, then we inject cement in it to stabilize it. So it's a totally different problem, a great solution for that problem for compression fractures, but not for spinal stenosis. Okay. Yes, I see a hand up there.
How can improving your core help with the pain in the legs?
Doesn't typically help with the pain in the legs. It helps when people have some back pain. So if you have a little bit of instability, improving your core will help diminish that instability. At least that's the reasoning behind it. So it can help with your back pain, not so much your leg pain. It's still a great thing because if you are going to have surgery for spinal stenosis or herniated disc or any kind of spine surgery, people recover a lot faster if they have a stronger core. So there's no harm at all to preoperative physical therapy. Yes, sir.
I had laminectomy and fuse 3, 4, and 5. What can I do to not promote 1 and 2 to go back?
Very little, unfortunately. Don't smoke. Avoid axial load activities. Axial load activities are things that cause jarring in your spine. So if you like to work out, don't run, ride a bike instead. If you can be in that position to swim, swim, because there's no load or there's no jarring on your back when you're doing that. So those are the kind of things that you can do. Don't smoke. That's something else also. So all these things are things you can do to help preserve your back as much as possible.
Playing golf help?
So, so here's the thing about golf. I think that, how old are you?
I'm 74.
Okay, so you've earned the right, in my opinion, to play golf if you want to. And no 36-year-old kid should tell you can't play golf. Listen, you got to do things that you enjoy in life. Otherwise, what the hell's the point of living? That's my personal philosophy. And, golf isn't the best thing for your spine because of that big swing that you do with the driver. So if you're willing to compromise, I'd say go play the pitch and putt. Use irons and don't use a big driver. You probably have a lower score anyway if you play more conservatively. And it's a compromise in life. And I think that you could certainly keep playing golf. Yes, ma'am.
This is a good follow-up to this question because I was thinking there are activities that I do that definitely aggravate it. Picking up grandkids, doing too much activity, going up and down the stairs too many times during the day. But if I rest, I get better in a few days and I feel much better. So am I hurting myself by continually doing those activities? Should I lay off? Because you said sometimes jarring and certain things can aggravate. So
what you're describing, when you have pain with increased activities and you stop those activities and the pain goes away, not pain, when I say increased activities, I don't mean pain with walking, but just pain if you're, cleaning your yard one day or shoveling the snow. That's typically not spinal stenosis. That can be either muscular back problems, which probably the majority of the times it is, or it could just be some minor degenerative changes where your disc is a little bit worn out, but you have no pressure on your nerves. And in that situation, you can do whatever you're comfortable with doing, honestly, and you can back off as you need. Now, if you said that whenever you walked you had pain, and it was limiting you from playing tennis or from doing things that you enjoy, then that's more typical along the lines of spinal stenosis. In either situation, you're really not going to damage things by doing activities. Your body's a really good friend of yours. It's going to tell you when you're doing something really bad, and it'll make you stop doing it. So these activities aren't going to harm you.
Well, I actually have been diagnosed with spinal stenosis, and so that's why I was asking, because I have the classic symptoms, and it seems to flare up if I go up and down the stairs too much, play with my grandkids too much, and my husband's like, stop doing all that stuff, you're just hurting yourself. But
so you have the classic symptoms of pain when you walk, you feel better when you sit, you grab onto your shopping cart? Yeah, well, if those symptoms it's not very typical. That's not a typical situation where those flare up and go. People will often have periods where they'll have an exacerbation of their pain. So people with spinal stenosis will have peaks and valleys. There'll be some really good weeks. There'll be some really horrible weeks. But it's typically not activity related like you're describing. If it is, then you're not doing any harm by doing any of that stuff. You can do activities as tolerated. That's what I tell most people. Yeah.
Do you have to have an MRI in order to really tell if you have
spinal stenosis? Yeah, you do. If you can't get an MRI because of a pacemaker or whatever other reason, then you can get what's called a CT myelogram. It's a CAT scan, but then they'll put a needle in your spine and they'll inject some dye so you can see the nerves. It's more invasive, so that's why we prefer to get an MRI first. And it's really important that the MRI or CAT scan that you realize that the MRI or the CAT scan is not the most important thing, once again. The most important thing is how you feel. So if you exhibit, like that young lady was saying in the back, if you have those symptoms of spinal stenosis, that's the most important thing. The fact that she has these symptoms that prevent her from walking long distances, get better when they sit, that's the most important thing. It doesn't really matter so much what the MRI shows unless...
They tell you you have it and you haven't had an MRI.
Or a CAT scan?
Yeah, haven't had anything, but they told me I had to.
They're probably predicting that you have spinal stenosis based on what your symptoms are. So if you have classic symptoms, I don't think that anyone can say you have spinal stenosis. The best thing you can say is you probably have spinal stenosis, and an MRI or a CAT scan would confirm it. So I would definitely get an MRI or CAT scan in that situation. Yeah, in the back.
Is this common to have that one side would be more affected than the other?
Likewise?
Yeah.
Yeah, so the question is it common for one leg to be more affected than another? Yeah, certainly. Your spinal cord gives off branches to your left and your right sides. And if it gives off branches to your left and right side, if there's more arthritis on one side or another, your left or right nerve can be pinched selectively. So yes, yes.
Left and right, that's interesting. It's not my legs, it's my lower back. Left side hurts, right side never does.
Yeah, so lower back, similarly, if those facet joints, those two joints in the back, if one is selectively more arthritic than the other, then sure, you can get more pain. And in that situation, one of those nerve ablation things may actually be a beneficial thing. Yes?
Is there any relationship between spinal stenosis and piriformis? It seems to me that when my back is hurting more, my piriformis is just spasming.
So likely not. If your back and leg pain go together, all common things being common, it's likely coming from the same source. So it's likely a back-related issue, not primarily a piriformis issue. Piriformis is a muscle in the buttocks, and there are nerves that exit below the piriformis. And people think that if the piriformis gets inflamed or enlarged, that can cause sciatica kind of pain. Classic people that get it are speed skaters because of all their activities and exercise. Their piriformis muscle gets really enlarged, and that pushes on the nerve. So likely not. Likely it's coming from the back at that point in time. No. No, likely not. Yes?
If you've already had the surgery and the fusion and all that, and you have nerve damage,
Would epidurals, is that would help?
It's certainly an option. So if you've had surgery once again and you're not better, you have to get another imaging study, make sure there's nothing else compressing that nerve. If nothing else is compressing that nerve, then there's no point for an epidural. If something is compressing the nerve, then an epidural is an option, and so is surgical intervention. If nothing is compressing a nerve, that's when a spinal cord stimulator, like we discussed earlier, would be an option. Yes, sir?
Yeah. My MRI shows that all my problems should be on the right side, and all my pain is on the left side.
Yeah.
What's going on?
Don't do anything about it. Yeah, I mean, you have to correlate your MRI to your clinical symptoms. I don't know. I don't trust anyone to look at an MRI but me. So I like to look at things myself. I don't trust a radiologist. I don't trust anybody but myself. And if I truly find nothing pushing on the nerves on one side and your symptoms are on the side with no pressure, but all your radiographic findings are on the contralateral side, that typically is not a good story, meaning I wouldn't operate on that person. So you just have to dig more deeply to find out what the true source of the pain is. Sometimes we'll use injections as a test. So let's just say you have at L3, L4 something pushing on the nerve on the left-hand side, but you have right-sided symptoms. That just doesn't make sense. But if I see a little bit of pressure on the right-hand side, I'll have you go get an injection on that side. If your pain gets better, then I know that I hit the jackpot, and that nerve is actually the reason why you're having your symptoms, and then I can operate on it. The most important thing in spine surgery in general, this is a little secret, the most important thing is making an accurate diagnosis. And to make the accurate diagnosis, it's not just looking at a stupid MRI or a CAT scan. It's correlating that to someone's symptoms and physical exam. The most important thing is making an accurate diagnosis. People often say, hey doc, so what surgery are you going to do on me? What am I going to do in the future? And I always tell them I can't answer that question unless I know what's really going on with you. So making that diagnosis is key. Sometimes it's as easy as just chatting with you and looking at your films, and sometimes it requires a series of injections, some diagnostic, maybe a hip injection to rule out the hip as a source, maybe an injection, in your spine to rule out your spine as a source, and kind of working around to try to figure out what's going on. Yeah.
I have a couple questions, and the first couple questions are related to having the arthritis. Is there and I was online today, so I got this on.
That's the most dangerous place to be, by the way. But
yeah. I think I got Mayo Clinic though. But anyhow, that you can put initially you can put some cold and then switch into hot. In other words, is it any for the arthritis to help it either?
Absolutely not.
No.
So cold and heat make no difference. It's just whatever feels better for you. Just like mattresses don't make a difference, pillows don't make a difference. If you go to the store, don't buy the $5,000 mattress, go sleep on them. Whichever one feels the most comfortable is the one you should buy, and often it's a $400 mattress, not the $5,000 mattress.
So, okay, so it's not, because often the arthritis is inflammation, and so you So
arthritis is not inflammation. Arthritis is wear and tear. Rheumatoid arthritis is inflammation. But the vast majority of people have osteoarthritis, which is wear and tear. So not necessarily an inflammatory process.
Okay, so this, I may not be doing this correctly, but I had my MRI here at U of M and Dr. Bakshi. And so if I understand this correctly, because of the arthritis and the inflammation, I have a cyst.
Okay.
So could you just talk about the whole cyst thing?
Yeah, so a cyst, as scary as it sounds, is just a fluid pouch, essentially. Every joint is surrounded by a capsule, and inside that capsule is fluid. You need fluid in a joint to lubricate it so you can have smooth motion. Just like in your engine, you have engine oil so your pistons can go up and down smoothly without wear and tear. Sometimes you get an outpouching of that pouch. So that little capsule where the fluid's in gets a little blip on it, kind of like a little water blister. Now, water blister it contains joint fluid, and people get that all over their bodies. People get it on their wrists sometimes. I'm sure you've seen that. People get it on their knees. I don't know if you've heard the term ganglion cyst, but it's all the same thing. It's just an outpouching of fluid from a joint capsule. Unfortunately, in the spine, when you do get that outpouching of fluid, it can compress a nerve, and that's what causes leg pain in some people. There are multiple ways to treat it. One is to go to someone like Rishi, and he can try popping that cyst and relieving the pressure from it. That's all it is, because it's like a little water blister. You can pop it, the fluid's out, and there's no more pressure on the nerve. If that fails, and surgically we'd go in and take care of it. Actually, I had a lady who was supposed to have surgery on a Tuesday. She fell in the grocery store parking lot on Monday, And when she stood up from the ground, her leg pain was gone. So she popped her own cyst when she fell, and she didn't need surgery. So, but that's what a cyst is. Yes?
You mentioned that sitting relieves at times spinal stenosis. Why would it be that sitting straight up causes more pain and slightly leaning back?
So if you are straight up or leaning back, you're extending your spine, and the more you extend it, the narrower the channel for your nerves to go. And if you lean forward, the wider that channel is. And some people, that's a general rule. Some people's spinal stenosis is so bad that no matter what position they're in, their nerves are just compressed. But the general rule of thumb is leaning forward. The more flexion you get, the better you feel. So people will often say when they're shopping, they only look at the stuff in the bottom row because they're pushing the cart the whole time. So sometimes you need to really flex forward significantly. Yes?
There's some way to distinguish between whether something's being caused by arthritic hips and arthritic and stenosis, which I know I have.
So a quick and easy way, what I do when I see someone is, so if you're sitting in front of me, I'll take your leg, and while I'm talking to you, I'll internally, I don't know if you can see me or not, but I'll internally rotate your leg, so just tweak it in. If your hip is really stiff and it doesn't move in, then there's a good chance it's coming from your hip. And if you rotate your hip in and that causes a good amount of pain, that means it's coming from the hip and not the back. So that's typically how we determine it. If you move the hip and it causes pain, it's coming from the hip. Yes?
Please, will you address the difference, well, the relationship between the back and leg cramps?
Yeah, so I mean, the whole relationship between the back and the legs is that you have the nerves in the back that go down to the legs. So if they're pinched, they can certainly cause leg cramping symptoms. Once again, it's all about the story. So if you say your legs are always cramping, then that's not really consistent with spinal stenosis. If you say they're cramping only when you start doing more physical stuff like walking and you feel better when you sit down, that's very consistent with spinal stenosis. Leg cramps can be from a whole host of things, not spine related. So unless you have a very clear story of spinal stenosis and an MRI that matches, I would explore every other option. And that would be referring you to a neurologist so they can work you out for other sources of leg cramps.
Yes. I think you may have answered this, I'm not sure. Can you have weakness in the legs but no pain with spinal stenosis?
Yeah, you can. It's not very common, but you can have weakness with no pain. Typically, the main complaint is pain. And when people say they have weakness, it's really hard to tell whether you have true weakness or whether it's fatigue or pain-related weakness. True weakness is, when we're testing you in the office, we can easily push down on your leg. We can easily bend your knee. And it's really important to distinguish between pain masquerading as weakness and true neurological weakness. But if someone just has weakness and no pain, I really, really want to make sure it's coming from the stenosis because there's a good chance it's not. Yes?
I had a laminectomy a year ago, and I'm having a lot of back pain and my buttocks and down one leg, but I also need double knee replacements. So do I start all over with the back, or do I get the knees done?
That's a good question. So I would say get the knees done, and I would say that for a couple of reasons. I think for rehab, if you want to rehab after back surgery, the most important thing is walk. You can't walk if you have two bad knees. Also, sometimes if your gait's off, that can cause back pain also. So I've heard of people having knee replacements, hip replacements, and their back pain improving significantly. Not going away, but improving to the point where they're like, you know what, I can live with this. I don't need another surgery on my back. So that's why I would address the knees first. Also, spine surgery is it's not as dangerous as people think it is, but it's also not as benign as knee surgery is. So that's why I would say address the knees first.
Do I have to worry about the pain going down the leg as far as any nerve damage?
If you have pain shooting down the leg in the sciatic distribution, then you probably have nerve impingement. In terms of nerve damage, as long as you don't have weakness, I wouldn't be so concerned about it. Okay, thank you. No problem. Yes?
I'm glad you brought up the knees. In 2002, I had knee surgery, bilateral, and a couple of years later, I had lower back pain. So Dr. Graziano put in an X-stop, and now I'm experiencing very great leg pain, and I'm in physical therapy right now. But you said something about keeping active with exercise, but because of the combination I'm not sure quite what I can do and what I can't do.
So as far as the next op is concerned, you have no limitations really at this point. You have no limitations.
I can't break it loose in any way?
You can, but you also have to have a fatalistic view of things. Chances of that happening are slim, and it's worthwhile for you to be as active as you can be. Now, people that have hip arthritis and knee arthritis and they have leg pain also, you really have to kind of wonder what's causing the majority of their leg pain. Is it the knees? Is it the knee implants? Is it the hip implants? Or is it the spine? So it really depends, and you have to really, once again, come up with that accurate diagnosis so you can offer a valid form of treatment. All right, yeah.
What is a good website, or what, I mean...
Yeah, that's a great question. There really is not a very good website to go to, and our website is really not that great. Our website's actually downright horrible at the University of Michigan. But we've just committed to, we just invested a lot of money and committed to improving our website. And the main goal to improve our website is to make it easier for patients to not only get access to us, but also to have a whole section on patient education. The reason why websites are not good is because you have patient testimonials and you kind of play that game of telephone where something gets lost in translation and people convey a message which isn't always true. A lot of the things that you read are by the companies that sell the products. So if there's a gender knee replacement, a company may be advertising it and selling it, and that may be what you read, but that's not always facts. That's what they want to promote. So there really isn't a very solid website yet. In about 6 or 8 months, hopefully, we'll have our website going, and our goal is to update our contents of our website, periodically, every 4 or 5 months, to keep things relevant, to keep new things in there, and also to keep it evidence-based. So just based on what the research studies have shown. Exactly, not anecdotal, and not for. We really don't have any incentive for putting that stuff on there. So it's not as if we're trying to sell something. It's just for patient education, just like this forum is. It's just patient education. Yeah, you had your hand up there for a while.
You mentioned that pain in sitting is typically not spinal stenosis. Is there something else that you see that is typical of pain when you're sitting, or is that more for a neuro?
Well, are you talking about pain in the back going down the legs? Yes. Yeah. Are you talking about yourself? Yes. Yeah. So how old are you? 41. Right. So you're young. So someone like yourself may have a disc herniation. So a patient with a disc herniation will typically have more pain when they sit, less pain when they stand. More pain when they sit, less pain when they stand, which is what a disc herniation would present itself as. Also, for back pain, if someone has degenerative disc disease just at one level with no pressure on the nerves, that can certainly cause a significant amount of back pain when they sit. When you sit, if you think about that tripod, you're flexing forward, you're loading that disc. And you're the perfect demographic for someone to have a bad L5-S1 disc. You're the perfect person for that, so that's probably what you have. Yeah?
If you help me speculate, when I sit at my desk all day, which is probably about the worst thing you can do, and then I run like for 7 minutes, and then I lose kind of sensation in the one leg. It's always the same leg, and then I keep running, and then it comes back. The sensation comes back.
Likely not spine related.
Not spine related.
Likely not, no. If it was, it would just keep getting worse and worse. It wouldn't come back.
Thank you.
No problem. All right, guys. Thank you guys very much for coming out. I really appreciate it.